This is the Integumentary System. It's Chapter 5. In this chapter, we're going to be looking at the integumentary system, which deals with the skin. It's going to help you to understand the normal functioning of the skin. So when there's some type of injury, you will be able to evaluate knowing what's normal, and then because of the injury, how it's abnormal, and how you need to treat it, repair it, etc. So the integumentary system consists of the skin. It is the largest organ in the body, but it also includes accessory structures such as your hair, your nails, sweat glands, and oil glands that are known as sebaceous glands. We're going to start off looking at the skin. There's two distinct areas or regions: the epidermis, which is the most superficial region, and then the dermis, which is directly beneath it or deep to it. The epidermis is composed of epithelial tissue, and it's avascular, so it does not have blood supply to it. The dermis layer, which is deep to it, is mostly fibrous connective tissue, and it is vascular. Now, but deep to the dermis, so right below it, is the hypodermis, sometimes referred to as superficial fascia. This is oftentimes also referred to as the subcutaneous layer because it's below the skin. It's not technically part of the skin, but it's always included with it. It does share some of the functions for it. It's mostly composed of adipose tissue, which acts as essentially a shock absorber and an insulation layer. It does help to anchor then the skin to the underlying structure, which in most cases it's going to be muscle. So, in this diagram, it is showing a cross-section of the skin and the various layers. So you can see the most superficial layer here is the epidermis, and then the dermal layer. In a moment, we'll talk about how it's subdivided into two layers. Then the hypodermis is this layer here. Like I said, it does contain a lot of adipose or fat tissue in it. You can see that the dermis layer does have this nice supply of blood. That's why we say it's vascular. But the epidermis layer up here does not contain blood vessels, so it's avascular. It is dependent upon the blood vessels that are just beneath it in the dermal layer and diffusion of oxygen, diffusion of nutrients to be able to get up to supply these cells right here. And we're going to talk about each of these layers in just a moment in a lot more depth. But you can also see there's the hair follicles. You have some muscles here. We'll talk about this. And some of these glands. Some of these glands are attached to where the hair follicles are. Some of them are separate. So we're going to start the top, a more superficial layer, and work deep. So we start with the epidermis. The epidermis is mostly what we call stratified squamous epithelium, and it's keratinized. There's four main cell types that you're going to find in the epidermis. The first type are the keratinocytes. They produce the keratin. That's a protein. It gives a lot of the protective properties to the skin. It's very hard for microorganisms to be able to pass through this fibrous protein that's present there. This is the majority of the cells in the epidermis are the keratinocytes. They're very tightly connected, and you actually lose millions of these cells every day. That's just normal functioning. There are also melanocytes. These are cells, they tend to be a little bit deeper in the epidermis. They do produce a pigment called melanin. Melanin is sometimes referred to as kind of nature's sunblock. It's a protective pigment, if you will. It's produced, UV light has a problem passing through the melanin. So this pigment tends to just naturally form on the more superficial side of the nucleus. In other words, it acts as a block of incoming UV light before it can, if it's penetrating through the cell, before it can hit the nucleus, you tend to have the melanin pigment on that side, and it prevents the UV light from hitting the DNA where it can cause damage. The dendritic cells, also known as Langerhans cells, these are a type of macrophage. A macrophage is a cell that can engulf, basically eat, any type of foreign debris. So these are scattered throughout the epidermis and are part of your immune system. Think of it as they're on reconnaissance. They're on patrol, kind of looking for any type of foreign debris to keep it from penetrating further. And then you also have the tactile cells, also known as the Merkel cells. These are sensory receptors. They can sense touch. So how many layers of the epidermis do we have? There's either 4 or 5, depending on where you're looking in the body. Most areas contain 4 layers. However, the 2 areas that contain 5 layers are going to be the palms of your hand and the soles of your feet. That is where you will find 5 layers of the epidermis. It's areas where you need some extra protection because they get a lot of wear and tear and abuse, and so you need some extra protective layers there. The 5 layers of the skin, starting the most deepest layer, moving more superficial. You have the stratum basal layer, excuse me, the stratum spinosum, the stratum granulosum, the stratum lucidum, and then the most superficial layer, the one that you see, is the stratum corneum. Now, the extra layer that's found only in the thicker skin areas of the soles of your feet and palms of your hand is the stratum lucidum. The stratum basal, we're going to look at each of these layers individually. This is the deepest of all the layers. As the name implies, basal, it's that base layer. So it's going to be attached to the dermis. It has a row of stem cells. Stem cells are cells that have not differentiated yet, meaning usually their purpose is just to go through mitosis and produce new cells. And then those new cells will receive the message, if you will, as to what kind of specific cell they're supposed to become. So there's usually this row of these stem cells that are actively going through mitosis, through cell division, and the resulting is they produce 2 new daughter cells. One of those daughter cells will stay and continue to go through mitosis. The other daughter cell gets pushed up and eventually will reach the surface of the skin. How long does that take? Oh, it's been estimated between 25 and 45 days. Now, by the time it gets to the surface, it's going to be dead. Like I said, that other daughter cell is going to remain at this basal layer so that it can continue going through mitosis. Some books may refer to this layer instead of the stratum basal as the stratum germinativum, and that is because it is actively going through mitosis. Now, it's in this layer also where you would find those melanocytes that are producing the melanin pigment. The stratum spinosum layer is the second layer. It's usually very thick, several layers thick. You do have keratinocytes in this layer. They look kind of spiky. You have different dendritic cells also through here. Excuse me. The stratum granulosum is about 4 to 6 layers thick. Now the cells are starting to flatten, so it looks really thin, and you're starting to see some changes in the appearance of the cells. That's why I say they flatten. This is where the nucleus and the organelles are starting to disintegrate as the cell is dying. Why is the cell dying? Because it's getting further and further away from that basal layer. And remember, the epithelial tissue does not have a blood supply. It's avascular. So, as I mentioned at the beginning, it's dependent upon the underlying dermal layer to provide the nutrients, the oxygen, those materials that are necessary for cell survival. Things can only diffuse so far distance-wise. And so now what's happening with the stratum granulosum layer is that you're getting far enough away that the nutrients and oxygen are not getting this far. The cells beneath them are using them up. And so the cells are going to start to die. Now, one thing you will see is that the cells will start to accumulate different granules. It's going to help to form the keratin fibers in those upper layers, which has a protective mechanism for the skin. The stratum lucidum, this is that extra layer that's only found in the thick skin areas, like I say, the soles of the feet and the palms of your hands. It's a couple of layers or rows thick. The cells are dead at this point. So the stratum corneum, this is the outermost layer. This is the one that you see. It's several layers thick. At this point, the cells are dead. They are anucleated, meaning there's no nucleus in it. The nucleus has disintegrated. Now, even though the cells are dead, you might think, well, okay, they're useless. No, they're not. They are in very thick layers, and the way they're tightly held together, it helps to prevent water loss. It helps to protect all those cells that are beneath them. It helps to protect you from any types of scrapes and abrasions. You know, you'd rather lose some dead cells than the living cells. It is very effective at helping to prevent penetration by microorganisms. So think of it as, yes, it may be a dead layer, but it's a very effective physical barrier. So that, once again, if you're to be exposed to some chemical, if you're to be exposed to something biological, such as microorganisms, you have this layer there. You'd rather it go against these dead cells. It can't kill them because they're already dead. But they're all tightly lined up, and it's a protective layer. Oftentimes, microorganisms have a problem actually penetrating through this layer to get into you, which for us, that's a good thing. Bad for the microorganism, but it's good for us. So even though they're dead, it's a very good layer. And yes, it's true. Most of what you are seeing on the outside of a person, your skin, that's all dead cells. So cells are going to be going through different changes as they're moving up the layers towards the surface, called apoptosis. This is a very regulated and controlled type of cell death. Now, what happens if down at the basal layer you have cells constantly going through mitosis? And I said it takes about 45 days for the cells to push all the way up to the surface. So why aren't we getting thicker and thicker? Because those dead cells are going to be sloughed off. If you've ever seen anyone with, say, dandruff and dander, that's dead cells that are being sloughed off. Humans shed about 50,000 cells per minute. I'm sure that's not a number that some of you maybe wanted to think about or hear about, but that's just normal. It's also, when I teach microbiology, another thing that I often mention with this, with you sloughing these cells off, like I say, you have microorganisms on the surface of your skin. And that's a good thing. That's not bad. You're supposed to have naturally some microorganisms there. This is a good thing. They actually help to protect you as well. And if the space is taken up by a good one, then that means a bad one can't get there. But let's say a harmful bacteria does get on the surface of your skin. Well, if you're sloughing off these dead cells, oftentimes when you slough them off, you're sloughing off the microorganisms that are on them. So it's another protective mechanism of trying to keep you from getting infected. So this diagram over here on the left is show from a microscope looking at the actual cells, and then you have on the right the schematic drawing of this. So this layer, this is the dermis. We'll see in a moment that it's not flat. So you have these little ridges, these up papillae is what they're called here. Excuse me. So it's right in here where we have the stress and basal. That's where the mitosis is going on. The stem cells are going through mitosis. One stays down, one daughter cell gets pushed up. And then now we're into the stratum spinosum. It's several layers thick. Stratum granulosum. The cells are disintegrating now. That's why it looks like there's all these granules. Not only the nucleus, but all the organelles are starting to disintegrate. And you get all these, as they disintegrate, you get all these granules forming in the cytoplasm. And then this does not show the stratum lucidum. It would be right in here. And then your stratum corneum. So, of course, all of this, see how the cells are flattened out? These are all dead. But the way they're flattened out in the arrangement of it, it prevents water loss from inside moving out, and you're losing water, becoming dehydrated that way. And they're tightly connected, so it's helping to prevent anything from trying to penetrate down through those layers. The dermis is, so the epidermis is made up of epithelial cells. If you remember from your lab, epithelial tissue always has one free surface to it. The dermis is made up of connective tissue now. And the dermis layer will have blood vessels, it will have nerves through it, does have lymphatic vessels through it. Now the epidermis, I will mention, it does have some free nerve endings in it. So just be aware that all of you have had this happen. If you, say, cut your finger, you're going to know it, even like a paper cut. You're going to know it because there are free nerve endings all over. And you hit one of those, you cut one of those, you're going to feel it. Now, let's take a paper cut. You get a paper cut. Why is it that sometimes they bleed and sometimes they don't, but you always feel them? It's because the free nerve endings in the epidermis would have been stimulated. If it does not bleed, then that means you have a very shallow cut and you only cut within the epidermal layer. You did not go as deep as the dermis. There's no blood vessels there. That's why it's not bleeding. If it does bleed, then that means you did cut down to the dermal layer, which does contain blood vessels. So that's why it's bleeding. So it's connective tissue. It does contain fibroblasts and macrophages. Sometimes there may be some white blood cells in there that are trying to deal with infections or on reconnaissance, if you will, looking for any foreign type of material. There's fibers that are in the matrix. Remember, the matrix is the material outside the cells. It's helping to hold the connective tissue all together. It can contain hair follicles itself from the dermal layer, how it extends down. There's two layers of the dermis. There's the papillary layer and the reticular layer. So if we look at the cross section, here's the epidermis all the way down to right. So this area where it's orange, these are the dead cells here, all the way extending to this point. Between kind of that greenish color and the white is the epidermis. Below all this is the dermis. And you notice how it looks a little bit different. The papillary layer is the most superficial one that is going to be connected right to the dermal. The epidermis and dermal are connected here. And then the reticular layer is below the papillary layer. The papillary layer, as I just said, it's the most superficial one. It's connected to that epidermis. It's composed of areolar connective tissue. You do have those blood vessels through there. There's loose fibers. That allows for phagocytes to be able to move very freely in amongst that matrix. I say, what are they doing? Well, they're looking for microorganisms. They can distinguish between your cells and what we call non-self, things that are not you, and they will, a phagocyte will engulf, basically recognize this is foreign, it's not supposed to be here, it's not part of you, and so I'm going to eat it. The dermal papillae, these are regions of the dermis. Those are those little projections up into the epidermis. They do contain a lot of the capillaries, free nerve endings, etc. that are in there. It's increasing the surface area. So this gives rise to what's known as epidermal ridges, which is what you know as fingerprints. The little lines and ridges that you see on your toes and on your fingers. Anatomically, we refer to them as friction ridges. Why do you have them? It helps you to grasp better. Think if you have sweaty palms. If it were your fingers were a completely smooth surface without those ridges, it would be very hard to hold on to things. So it does help with your ability to grip or grasp onto things. It does help with your sense of touch. It does leave these unique fingerprint patterns, which are genetically determined, and they are unique, obviously, to each individual. So this is just showing kind of the fingerprints here. Okay, to a science nerd like me, it's like, oh, isn't that really cool? You can see the pore openings for the sweat glands. The reticular layer is thicker than the papillary layer. It's composed of that dense fibrous connective tissue. It does have elastic fibers within it that help with that ability to stretch and then return back to its original shape. The collagen fibers also provide strength and resiliency. It helps keep the skin hydrated. If you read about the cutaneous plexus, that's referring to this whole network of blood vessels that exist between the reticular layer and then the hypodermis layer beneath it. Within some of the matrix, there are areas where there will be some adipose cells. Not as many as what's going to be in the hypodermis, but there may be some there. Cleavage lines or tension lines in the reticular layer, these are caused by the collagen fibers. They tend to run parallel to the skin surface. So you can't see these. It's not like you see all these lines, but a surgeon knows where they should be running. And ideally, what they will try to do is they're going, a surgeon has to do an incision, when he has to cut, he's going to want to try to do the incision parallel to these lines because they have found that it will heal faster and typically with a little bit less scarring as well. So in this diagram, I said, you can see where, I mean, you cannot visibly see on your body these lines, but on this diagram, you can see how these cleavage lines run. So a surgeon is ideally, given a choice, they would like to go parallel to these lines. Like I say, they have found that it'll heal faster and typically with a little bit less scarring. Now, you know, it depends on the situation, whether they're actually able to go right along the line or not. I'll just say from my own personal experience, years ago I had a spot of skin cancer on my neck right around this area, and the doctor who did the surgery afterwards, when I was going in for a follow-up, she was a little upset with herself because she kind of did the incision a little bit against some of those cleavage lines. And she tried her best to go along it, but she did have to go a little bit at a different angle and crossed over some of them. So she wasn't happy with herself. Now she's a bit of a perfectionist, and she's like, oh, yes, it's healed fine, but I didn't go on the cleavage line. Well, of course, for me, I'm like, did you get all the cancer? And she's like, well, yes, But your incision site, you might have a slight scar there because I didn't quite get it on the cleavage line like I wanted. I didn't quite go parallel, like crossed over some. I'm like, but did you get the cancer? And she's like, well, yes. I'm like, then I don't care. I don't care if I have a slight scar on my neck. And she's like, yeah, but that scar is going to be, I don't care. So sometimes they get a little uh, bit of the perfectionist in them. They're trying to leave as few scars as possible. But you hear them talking about uh, cleavage lines. Say if you're having abdominal surgery, they may try to go a little bit more along those. It may influence how they do the incision. But to me, the bottom line is have a successful surgery. That's the most important thing. Flexure lines are where you have some folds out under your joints. It allows the dermis to be very tightly secured because along the joint you're going to have movement there. Um, you can see some of these on the wrist, on your hands, etc. So that's what these are. These lines. These are referred to as flexure lines. Extreme stretching of the skin can cause some dermal tears, and then you end up with these scars once they try to heal. Anatomically, they're known as striae. Common language is stretch marks. Um, it's something that will happen in certain situations. Sometimes you have trauma to the skin where you're going to form a blister. And what a blister is, at some point, all of you have had one, you know that it's these little pockets, little areas that are filled with fluid. It's actually between the epidermis and the dermal layer. So this is an example of some stretch marks or the striae. For women who have been pregnant, especially multiple pregnancies, uh, you tend to get these. It's probably going to happen. In terms of skin color, there's 3 different pigments that can contribute to the overall skin color. The first one is melanin. Mentioned this earlier. This is produced by the melanocytes. It's the only pigment that's actually made in the skin. As I said, it's kind of nature's sun block because it's helping to protect the DNA from the UV light. There's different forms of it. There's a reddish yellow all the way to a brownish black. All humans have the same number of keratinocytes. So what attributes to the different amount of melanin? Well, it's how much melanin is being produced by the melanocytes. This is determined genetically. Keratin is another pigment that helps to influence skin color. Keratin, there's different ranges of it, can be from yellow to orange. It becomes most obvious typically in like the palms or the soles. It tends to accumulate in both the stratum corneum on the surface as well as on the hypodermis. Keratin is important because it can be converted to vitamin A, which is necessary for one big thing is for your vision. Keratin is the pigment, like I say, it's yellow to orange, that's found in a lot of your yellow-orange vegetables, carrots, squash, pumpkin, things like that. And you might be thinking, how does it really attribute to skin color? It's more obvious on very fair-skinned individuals. If you consume a lot of, say, these vegetables that have keratin in them, a lot of those yellow-orange vegetables, then you tend to get an accumulation of the keratin. And like I say, it can accumulate in the stratum corneum. If it's down the hypodermis, you're not going to see it, but in the stratum corneum, that outermost layer, you can start to get kind of a yellowish hue or orangish hue to your skin. Sometimes this is more obvious in young infants. Any of you who are parents may have seen this. When you have a young infant and you're starting them on solid food, and when you hit the point of where you are adding, say, the carrots and the squash and the pumpkin, for someone who is very, very fair-skinned, you may see the accumulation in, for whatever reason, they'll say like on the fingers, the soles, but the other place is on the nose. On the face, you start to get this yellowish hue to it. But that's going to be more obvious, like I say, with someone who's very fair-skinned. Darker skin, it's not going to be quite as obvious. The third type of pigment is hemoglobin. This gives kind of a pinkish color to especially very fair-skinned people. So it's going to be more obvious in Caucasians just because the skin coloring is lighter. The hemoglobin is a component of the blood. It's what binds the oxygen. So if you have excessive blood flow, like somebody, maybe they get embarrassed, you tend to have more blood flow to the face, and then they look, oh, you're red in the face type thing. You'll notice through these chapters as we study that periodically there are these clinical little applications. Here are some real world applications on the concept or topic that we are talking about. So exposure to sun. You need to be out in the sun somewhat, as we'll see in a moment. But excessive sun exposure can damage the skin. Now you want to have a little bit because there is a process that occurs. Exposure to some UV light does help a process with some chemicals in the skin that are the precursor to forming vitamin D. And why do you need to have vitamin D? Vitamin D, when UV light hits you, it starts the process of converting one chemical to another, and then it's eventually going to move it to the liver, and from the liver to the intestines. So once again, why do you need vitamin D? Vitamin D is necessary to help with calcium absorption. You can have all the calcium you want in your diet, but you cannot absorb it through the intestines without the assistance of vitamin D. So that's why it's kind of catch-22. You need to have some exposure to start this process for basically developing the vitamin D so that you can absorb calcium. Why do you need calcium? Because you need that for muscle contraction, you need it for nerve impulses. So you need to have a certain amount of calcium. So you could say, oh great, we just gave you permission to be out in the sun all the time. No, not exactly. Excessive sun exposure is going to damage the skin. It's going to cause those elastic fibers to start clumping, and over time it's going to cause the skin to look real leathery, like leather basically. Too much exposure can also depress the immune system, and the UV light can also have adverse effects and cause mutations in the DNA. Over time, it can lead to skin cancer. It is a very slow process, but so you may not see the damage for 20, 30 years, but it can happen. UV light also destroys folic acid. Folic acid is necessary for DNA synthesis. So if you have insufficient to low levels of folic acid and a woman is pregnant, this can be very dangerous for the developing embryo because you're developing the DNA and you can end up with long-term very adverse side effects. Photosensitivity is often increased reaction to the sun. Some drugs will cause this. So you need to be careful sometimes if you're taking antibiotics or if you're on antihistamines and certain other medicines. It can cause photosensitivity, which means normally you might not have a reaction when you're out in the sun, but you go out in the sun and you might come back in and go, why do I have this rash? What happened? It's because the medicine that you were on, those chemicals, increase your sensitivity to the sun. What are some things that can cause changes in the skin color? And some of these can be indicative of certain diseases. Cyanosis, this is a blue skin color that's indicative that you have very low oxygen, which that needs to be corrected as soon as possible. Just on a side note with cyanosis, something to keep in mind, oxygen levels are lower when you go up in elevation. So if you move around and who knows where you may be working and living in 10 years, just kind of keep that in mind. That's, let's say you end up going and working up in the mountains. Just be aware that the atmospheric oxygen concentration is a little bit lower, and you'll find some differences there. As an example, I lived in New Mexico for over 20 years, and it was interesting one time listening to a story of a paramedic who had come to Albuquerque. He was on some type of an exchange thing, so he was there temporarily for a couple months, and he was telling the story of they received a call of a woman who was pregnant and was about to give birth, and they got there and they ended up having to deliver the baby. And he was telling the story, after the fact, about how he got very nervous because they delivered the baby. Mom's fine. And this visiting paramedic who came from someplace that was near sea level was quite concerned because he noticed that the newborn had kind of a bluish color. Well, the paramedic that he was working with, who was from Albuquerque, did not seem that concerned. And the baby took its first breath, was crying. From that standpoint, seemed fine. But he's trying to quietly tell the other paramedic, without alarming the mother, of this baby has a blue color. Not like blue, but there's a little bit of a bluish tinge. And should we put oxygen on, or should we be concerned? And the other paramedic, oh no, the baby's fine. And he's trying to be a little bit more forceful. Once again, without alarming the mom, they're trying to transport her now to the hospital to say, the baby's blue. The baby is blue. This is not normal. We need to be doing something. And then, oh, no. And finally, later, it was explained to him, Albuquerque is a mile high. It's at 5,300 feet above sea level. And when you're at these higher elevations, there's less oxygen, and it's fairly common there, in some instances, for the babies to have initially, and I'm not talking obviously for long term, but initially may have a little bit, as they take their first breaths, a little bit of a bluish color. Just be aware of this. Now, I'm not saying that you sit back and you wait, oh, the patient's turning blue, let's just wait and see what happens. No. That is a sign. At least start monitoring, but be aware of where you're at. Things are different at Santa Fe, New Mexico is at 7,000 feet. Things are different at 7,000 foot elevation than at sea level. So that's all I'm saying, is to be aware of some of that. Redness, erythema, this can be triggered by fever. It could be triggered by hypertension, it's high blood pressure. It could be part of the inflammation response. You could have an allergy response. A pale color, known as pallor, that could be due to low blood pressure. It could be due to fear. People have often said, oh, you're white as a sheet. What? Somebody was really frightened. Jaundice is indicative of liver disorders, and that tends to give a yellowish coloring, especially in like the whites of the eye for jaundice. Bronzing, This is often due to inadequate levels of some of your hormones, such as some of your steroid hormones. And then certainly, unfortunately, all of us have had bruises where you get black and blue marks. And what is this due to? Because you had some type of a trauma or injury. Some of us are klutzier than others. And you had some blood clotting beneath the skin. And it goes from the lovely black and blue to kind of the purplish and then the yellow, and you can watch the whole progression of colors. The hair. Hair is composed of dead keratinized cells. Um, what's the function of hair? Well, it does help to warn you of things on skin. You've all had this where you may be sitting and maybe on your arm you feel this slight sensation as though there's a spider or a mosquito or something that is walking on your skin. How do you know it's there? It's the hair. It's being moved, and that movement triggers receptors to give you the sensation that there's something walking, across my skin. So now how many of you are now rubbing your arms thinking, oh, why did she have to say that? The hair on your head helps to actually give another layer of protection. The hair helps to prevent heat loss. And it does help to shield the skin from sunlight. So there are a lot of protective mechanisms or properties of the hair. So as I said, the hair itself are strands of dead cells. So between the hair being dead and the outermost layer of the skin being dead, once again, I hate to say it, but everything you're looking at pretty much other than your eyes is dead. Where is the hair being produced? By the hair follicles. It does contain keratin that's very hard. It's not like the keratin in the skin. It's very hard. It's more durable. The cells aren't going to be flaking off. And you know by now that we love in biology to classify things. So we're going to divide the hair into different regions because it is much too easy to just call it hair. So the hair shaft is the area that extends above the scalp. The root is within the scalp, so you don't see the root. This is where the keratinization is still going on. Three parts of the hair shaft. You've got the medulla, the cortex, and the cuticle. The medulla is in the innermost portion. It's that central core. The cortex is going to be surrounding the medulla, and then the cuticle is the outermost layer. Just a little piece of advice or a hint for studying. You will see the terms medulla and cortex again as you study A&P, and just always know that the medulla is going to be the innermost and the cortex is going to be surrounding it. An example would be when you study the kidney. The internal part, the central core of the kidney is referred to as the medulla, and the outer surrounding that medulla area is known as the cortex. So just kind of keep that in mind. Whenever you see medulla, think central core, and then surrounding that will be the cortex. There may or may not be a cuticle surrounding that, but that's going to be the outermost one. And in the case of the hair, the cuticle is the outermost one. Hair pigment is determined by the melanocytes that are present in that hair follicle. There's a combination of different colors. There's yellow, there's a rust, there's a brown, and a black. There's an additional pigment that's involved with red hair. So you get a combination of these to get the various hair colors. And this is determined genetically. Environmental factors certainly can play a role. Stress often results with graying hair because it may decrease the melanin production. And so if you have a decrease, you end up with a gray or white hair. And obviously different chemicals can have effects on the natural coloring of the hair as well. So this is a cross-section of the hair showing the various layers. Like I said, the innermost one is the medulla, then you've got the cortex, and then the outermost is the cuticle. So the hair follicle extends from the epidermal surface all the way down to the dermal layer. The hair bulb is that area that's very deep. The hair follicle receptor, also known as the root hair plexus, is this area where you have the sensory nerve endings. They're going to wrap around the hair bulb. Um, and so it's going to be able to pick up, like if you pull it, it's going to feel it. There is several additional layers of the wall around the follicle where there's connective tissue. There's a membrane, and then you've got the root sheath. So the hair matrix, that's the area of the bulb where the hair is actively, cells are actively dividing, and what happens is as a cell divides, kind of like what we saw with the epidermis, one cell stays there and then it pushes the older ones upward. And so it keeps getting pushed up. The erector pili is this little small smooth muscle that is attached to the follicle. And when it contracts, it's going to pull that hair follicle straight up. And that's when you get goosebumps. It is smooth muscle, which means you do not have any voluntary control over it. The hair papillae, this little conglomeration or group of capillaries that are supplying the nutrients to the growing hair cells. So here's where we're looking at right here. So here's the dermis, here's the subcutaneous layer here. Here's the hair papillae. Like I said, it's got the capillaries, blood capillaries providing nutrients, oxygen, etc. You have those actively growing cells here. They're being pushed up. The melanocytes that are providing the pigments to give the coloration to the hair as it's being pushed up. There's different types of hair. Vellus hair is really fine body hair that tends to be seen on children and adult females. Terminal hair is the coarser, longer hair that's found on the scalp. It's found in the eyebrows at puberty. It's going to appear in the axillary regions, the pubic regions. In males, at puberty, it's going to start to appear on the face and the neck. Nutrition and hormones will affect the hair growth. Other environmental stresses can also affect hair growth. So the follicles are going to kind of cycle between being active and kind of inactive for a bit. Everyone knows when you comb or brush your hair, you get the hair follicles. So how many scalp hairs do you use? On average, you lose about 90 per day. Now with women, the ovaries and adrenal glands do produce some amounts of the androgens, which are the male sex organs. But if there's a tumor on the ovaries or a tumor on the adrenal glands, it can trigger excessive amounts of these male sex hormones to be produced. And what happens is the woman would have excessive hairiness. How do you treat it? You would remove the tumor, and then that should solve the problem. Hair thinning and baldness. Alopecia is hair thinning more excessively, typically after the age of 40. True baldness is determined genetically. Male pattern baldness is one type of baldness that can be triggered by response to different hormones. What can trigger hair thinning? Well, very high fever, surgery, like I say, any type of trauma, including emotional trauma. Certain drugs can have effects. Protein deficient diets, like I said, nutrition plays a role. There are certain immune type of diseases that can have an effect. Some hair loss is reversible, but others are permanent. Couple things to add on this with drugs. One of the type of drugs that can certainly play a role are some of your drugs that are used in chemotherapy. Certainly, most of you have heard or realized, and unfortunately some of you may have, friends, family, etc., who have had to go through this, where they're under chemo and radiation treatments, and they do end up losing their hair. And this can be more traumatic for some people than others, that they're already dealing, say, with cancer and trying to emotionally deal with that, and then they lose the hair. It's just another, it's kind of like another punch to you, that dealing with uh, the side effects of these drugs. Another thing that I do want to mention that's not brought up here, which I feel should be mentioned to individuals. Like I was saying, normally you lose about 90 strands of hair a day, 50 to 90 a day. When a woman is pregnant, one of the side effects of the hormones, if you will, is that that number tends to decrease. And so pregnant women tend to lose a little bit less hair on average. And this is just an average. Of course, everybody's individual experience is going to be different. And that kind of leads to, okay, a pregnant woman's losing less hair per day, and it leads to oftentimes, you may hear a pregnant woman talk about, oh, my hair is so nice and full and thick. It's never been this thick. And isn't this great? And I feel wonderful. The thing that I always feel should be mentioned, and I've had to explain this to individuals over the years who've become very upset, that I wish doctors and or nurses would explain to the new mom, is that, okay, she's lost less hair during the pregnancy, but after she delivers that baby, and it's not like immediate within 2 days after having the baby, but sometimes it can be extended out to, 2 months afterwards or so. As the hormones are all adjusting, getting back to normal, it's almost like the body, and this is worse in some people than others, but it's like the body kind of goes, oh, we kind of have to make up for that lack of lost hair. And so sometimes a month, 2, even up to 3 months after a woman has had a baby, then she may suddenly notice a lot more hair loss, which it comes oftentimes at a time when the mom, she's adjusting to this newborn, she's probably not getting, enough sleep, and then finally she might just be kind of getting her life somewhat back in sync, and I think I got this figured out, and then she starts losing her hair, and nobody ever tells them about that. And like I say, I've known a woman who've come to me who's like, oh my God, what is wrong? There's something drastically wrong with me, and I can't get sick now because I have this newborn. But I actually had a woman one time, I don't know, am I dying because I'm losing all my hair now? It's like, no, 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 no. This is normal. It's okay. You may not think it's okay, but it'll all work out. And it's one of those things they often don't tell the new mom, that I wish they would just, at least, this may not happen, but just be forewarned. It's okay. It just happens. Your nails. Nails are another accessory structure, if you will, of the integumentary system. They are considered a modification of the epidermis. They are composed of hard keratin, as you know. It's very hard. It's protective cover, basically, for the very end of your fingers and toes. You have a free edge to it. You have the nail plate, and you have the root. The nail bed is that epidermis that's underneath the nail itself. And then the nail matrix, that is the area that's responsible for the growth. The nail folds, that's the skin that's along the border of the nail that's helping to hold it in place. The eponychium is the fold that's going to project onto the surface of that nail body. It's also what's commonly referred to as the cuticle. The hyponychium is the area under the free edge. That's the area that accumulates the dirt that you're always having to clean. Now the nail should be pink because there are capillaries underneath it and gives that pink coloration to it. Where you have the thickened nail matrix, it's going to look white. That's known as lanolin. Now, if you have an abnormal color or shape to the nail, that can be indicative of various disorders and diseases. So in this diagram here, this is showing the free edge, the body, the epinicium, which is also known as the cuticle here. Here's the lanula, the white area. Like I said, this should be pinkish in color because you've got these capillaries underneath it. And underneath the nail, right underneath the hard surface that you see, that pink area, that's the nail bed. The nail matrix is back here underneath the skin, below the cuticle. That's where the cells are actively growing and pushing the nail out. Now, the nail, like I say, different in colors, shape to it, if there's ridges on it, that can often be indicative of different disorders. One thing you may not fully be aware of when you go to the doctor, sometimes the nurse may be looking at your hand. Like if she's grabbing your hand to do a pulse, she may be glancing at your nails to see what they look like. A lot of chemicals will accumulate in the nails, and so when they are doing an autopsy, they will take clippings of the nails and do a chemical analysis of it to see if there are any toxins or drugs, etc., that may be present there. They'll also do that for hair because it will also accumulate in the hair. So chemicals, toxins, drugs, whatever, can accumulate both the nail and the hair, so they will analyze those. Someone who is going through chemo, radiation type treatments, they are going to want to also be looking at their nails. Like I say, it can give you clues as to how things may or may not be progressing. Are there any other secondary type of things you need to be aware of? This, just so you know, can be very frustrating for the patient. Just keep in mind as you're going in the healthcare field, obviously, you're usually not going to be seeing patients when they're at their best. If you're dealing in an oncology unit, dealing with cancer patients, this is something with the nails that you may say, okay, well, the patient cannot be wearing nail polish because we have to be able to observe the nails. We want to see the coloration of them. We want to look to see if there's any abnormal patterns, because that can give us clues if there's too much accumulation of certain chemicals, etc. So they're going to want to see it. But for the patient, especially for women, just keep in mind that psychologically and emotionally this can be very tough. I know when my sister-in-law is a breast cancer survivor. When she went through, she had her surgery, and then she went through extensive chemo and radiation for 6 months. So she was on a cycle every 3 weeks receiving her treatments. And she started the treatments, and then she lost her hair. And that was tough for her. But she kind of had the attitude of, okay, I knew this was going to happen. I don't like it, but it's a necessary part of my treatment for me to get better. And so I know my hair is going to grow back later. And so for right now, where she was receiving her treatments, she was provided with 2 wigs, so she's like, you know what, I think I want one wig to be this color, and I'm going to try out some new styles. So she tried to be very positive about it. But then when it got to the point with her nails, when they told her during her treatment she could not wear nail polish, oh, I got a phone call on that one. Why can't I wear nail polish? And it's like, they want to be able to look at your nails. She goes, I've lost my hair. I'm going through this treatment. I am sick. this is a horrible thing to be going through. They cannot take my nail polish away from me. And I was like, well, they're going to want to see, when you go in for your visits, they're going to want to look at the coloring of your nails. It gives us a clue. For her, she handled losing the hair very well. It was being told she couldn't wear nail polish that really, really upset her. Now, in her case, she ended up saying, well, they can't tell me what to do. I'm going to put nail polish on, and I'll just take it off the night before I go in for my treatments. And anyone who wears nail polish knows, well, they're going to be able to tell that. But just be aware that for some people, you know, they're going through a horrible diagnosis, and the treatment is very tough. And you never know what's going to be the final straw for someone. For my sister-in-law, it was telling her that she couldn't wear the nail polish. Sweat glands. In biology, it's too easy for us to say sweat glands. So, you know, just to annoy you, we're going to call them the pseudoreference glands. Most of the skin does contain sweat glands. So whether you like it or not, you got about 3 million of them. There's two main types. There's the eccrine, which is also known as American sweat glands, and then apicrine sweat glands. So the eccrine ones are the most numerous. They're going to be found on the palms of your hands, soles of your feet, forehead. The ducts from the gland, there's ducts that will connect and open up as pores on the skin. So they're not connected to the hair follicles or anything like that. You have this gland, and the ductwork goes just straight opening up on the surface of the skin. That's known as the pores. They're going to function in thermoregulation. So when you get warm and overheated, they're going to start to sweat. They're often regulated by the sympathetic nervous system, which controls that fight or flight. You get really nervous, you get scared, it's going to start triggering them to release that sweat. That's why you get sweaty palms, etc. So what is sweat chemically composed of? It's mostly water. There may be some salts in there. There may be some vitamins like vitamin C. There could be some antibodies in there, some waste products, but it's mostly water. So the eccrine glands, like I was saying, those are the ones, as you can see, here's the gland right here, and you can barely see in this picture, but here is the ductwork that is opening up to the pore. There's another pore and another one there. Apicrine sweat glands, these are confined to the axillary and anogenital areas. They're going to secrete more of not just water, but more of a milky or yellowish type sweat that now is going to contain some proteins and some fatty substances in them. Now, the proteins in those fatty substances, bacteria really like. So bacteria in your body are going to start to break down the sweat, and the body odor is actually caused by the bacteria. It's actually, that body odor is caused by waste products of the bacteria that are breaking down your sweat. Some of your apicrine glands tend to be larger than eccrine sweat glands. They will start functioning at puberty. They tend to empty into the hair follicles. There are some modified apicrine glands. Modified ones in the external ear canal do produce cerumen, which is earwax, that's supposed to help keep substances from getting in the ear. It's supposed to naturally flow out of the ear and basically trap any foreign debris and bring it out with it. And then mammary glands, which of course are going to secrete milk. Your sebaceous glands or oil glands, these are going to be widely distributed over the body, but they are not on the palms of your hand. They are not on the soles of your feet. Most of these are going to secrete into the hair follicles, and they become stimulated when you go through that lovely time of puberty. They secrete sebum, which is kind of this oily substance. It does have bactericidal properties to it. Bactericidal meaning that it will kill bacteria, so it's a protective thing. It does help to soften the skin and soften the hair. You may not like the oil, but there are positive attributes to it. So once again, if we look at a cross section of the skin, remember over here, this was your sweat gland, your eccrine gland. Like I said, it's got the ductwork to go directly to the surface of the skin. It has that pore. Your sebaceous glands are going to be associated right with the hair follicles and drain into the hair follicle and be released along the hair. In this microscopic view here, the slide, you can see the sebaceous gland here. Here is your hair follicle, and the oils can be released along the hair. So what are whiteheads? These are blocked sebaceous glands. You have blocked that pathway there along hair, and it's blocked, so now the oil cannot get out. If that secretion becomes oxidized, it's going to take on the appearance of a blackhead then. Acne is usually when you have an infection along the sebaceous gland and you end up with a whole inflammatory response, and you result with a pimple. These pustules, you get the oil in there and the dead bacteria, etc., all in this combination of the pus. Overactive sebaceous glands in infants leads to what's known as, commonly referred to as cradle cap. It kind of starts as pink raised lesions, and then they turn into this yellowish brown, and eventually will then flake off. So that's when they're overactive. So what's the function of the skin? The function is it's a barrier. It is a physical barrier that protects you from the outside environment. So it's protecting and maintaining that internal environment inside you and protecting you from the outside. Anything outside has to pass through the skin in order to get to you. It's very important with helping to regulate body temperature. It does have various receptors that allow you to pick up sensations, what we call cutaneous sensations, be it cold temperature, that sensation of something walking on your skin, or pain. It's involved with various metabolic functions. It acts as a blood reservoir, and it's also involved with the excretion of some waste. So for protection, you're exposed to a lot of different things, microorganisms, chemicals. Some of us are klutzier than others and are constantly, banging up against something. You get a scrape. The skin is protecting you from that. It's protecting you from temperature extremes. So it's a physical barrier, it's also a chemical barrier, and it's a biological barrier. As a chemical barrier, the skin does secrete several different chemicals that are protective. Sweat contains, as we said, some antimicrobial proteins in it that will kill, whether it's a fungus, bacteria, etc. Sweat also contains sebum and defensives. Those will kill bacteria. The skin overall has a more acidic pH. Bacteria tend to prefer a neutral to slightly basic pH. They kind of like pH 7 to pH 8. They don't like it when you drop that pH below 7. As a microbiologist, we use this in the lab oftentimes. If you want to grow bacteria, bump the pH to about 7 or 8. If you want to grow fungi prefer a more acidic environment, so then you drop the pH. So the skin naturally is slightly below neutral, and so that inhibits some bacteria right there. And then another chemical barrier is the melanin, as I have mentioned before, that acts as a barrier against UV damage. As a physical barrier, you've got all those layers of the dead cells that are very tightly held together. They tend to block most water and water-soluble substances from entering. Now, some chemicals can penetrate a little bit into the skin. Sometimes your lipid or fat-soluble substances. Some plant substances, such as poison ivy, can penetrate a little bit. Some organic solvents like acetone, paint thinner, some drugs can penetrate through the skin, so we're able to put a patch on and it's able to penetrate through. So it depends on what you're talking about. Some things can pass, some cannot. In terms of a biological barrier, remember, oftentimes I mentioned about phagocytic cells that the epidermis contains, those dendritic cells that carry out phagocytosis. The dermis layer has macrophages, which also carry out phagocytosis. These are all working together to try to detect any type of foreign invader and attack it before it's able to penetrate deeper into the body. In the epidermis, some of these phagocytic cells, such as the dendritic cells, can engulf foreign invaders, but they're also going to activate the immune system when they do come in contact with anything foreign, so that you kind of get this whole combined response and effort. In terms of body temperature regulation, normal body temperature, 98.6 degrees Fahrenheit, 37 degrees Celsius. So under normal resting conditions, the sweat glands are going to be producing sweat, but at a low amount that you're not really even noticing it. And that's what we call insensible perspiration. You're not aware of the sweat. Now, if the body temperature rises, then the sweat gland activity increases, and you can sweat up to 3 gallons. Now, you're going to notice if you're sweating that much. That is called sensible perspiration, and that the whole reason is water carries a lot of heat. So when you sweat and you're releasing that water, you're taking the heat with it. It's going to cool you down. To cool, or in a cold external environment, what's going to happen, because the blood has heat with it, the dermal vessels will constrict. They're not going to stop the flow of blood to the skin, but it's going to decrease the flow, keep more of the blood flowing internally. And then that way you will decrease the amount of heat loss. This allows you to survive in very extreme temperature ranges. I've personally have been in temperatures as cold as minus 40 degrees and as hot as 119. Not saying I would do either one again, and it was not necessarily pleasant, but I'm still here. For cutaneous sensations, like I said, there are a lot of sensory receptors that are present in the skin layers that then, when they are stimulated, will send that information to the nervous system. Some of these are responding to stimuli outside, such as the temperature, be it hot or cold, touch, be it light touch or hard pressure. And then you also have free nerve endings, as I had mentioned earlier, that allow you to pick up stimuli that may be painful, dull sensations, or sharp pains. So once again, in this cross-section, you are seeing, remember, the epidermis, the dermal layer. Here's your nice vascular supply. Here you have some free nerve endings, some extending up into the epidermis. Here you have a sensory receptor. Here is the erector pili that is attached to the hair follicle. When this contracts, it's going to pull this hair follicle up, as we'll see in a moment. Here are your sebaceous or oil glands. Here is your sweat gland, your eccrine sweat gland. And once again, notice that the dermis layer and the epidermis is not a flat surface. You do have these ridges that is what forms your fingerprints. In terms of some of the metabolic functions for the skin, as I had mentioned earlier, helps to synthesize vitamin D. You have to have vitamin D to absorb calcium. There are chemicals from the keratinocytes that can also effectively break down and disable some of your carcinogens. Carcinogen is a chemical that can cause cancer. Keratinocytes can also activate some hormones. The skin naturally makes collagenase, which is going to help with breaking down collagen to try to help prevent wrinkles. As a blood reservoir, the skin can hold up to 5% of the body's total blood volume. And so when other activities are occurring, the blood vessels, they can either dilate or constrict to adjust for the blood flow. You're overheating, they dilate, having more blood coming towards the surface, so you're releasing some of that heat or more of that heat to try to cool you down. If you're exercising, you need more blood going to the muscles, so constrict. Like I say, you're not stopping, but you constrict and decrease the amount of blood flow to the skin. Why? Because you don't need it on the skin when you're running. You need it for the muscles. In terms of excretion, you're getting rid of some waste. So you can, by sweating, get rid of some waste products. Oftentimes these are some of your nitrogenous waste, meaning it's a chemical that has nitrogen in it. So things like ammonia, urea, uric acid. Sweating, you're also getting rid of excess water as well as salt. So what are some conditions that can affect the integumentary system? We can't discuss all of them, but we will talk about a few. There's many different disorders and diseases associated with the skin. And then just always keep in mind that we tend to cover the system separately, but remember they're all interrelated. So you can have other diseases elsewhere in the body that aren't directly involving the skin, but indirectly you will see effects of it on the skin. A lot of the disorders that we see can be infections. There are some less common ones that aren't infections that we'll talk about, such as skin cancer and burns. Most of your skin cancers are benign, meaning they're not cancerous, and they do not spread. When you talk about a cancer metastasizing, we're talking about it spreading from its original site. Most skin cancers don't do that. What are some of the risk factors? Well, number one, overexposure to UV radiation is probably the number one. And then frequent irritation of the skin. There are some lotions that they have now that contain enzymes that try to help repair some of the damaged DNA. This has some limited use to it. There are different types of skin cancer. It's basal cell carcinoma is cancer. So there's basal cell carcinoma, squamous cell carcinoma, and melanoma. Basal cell carcinoma is the most common and it is the least malignant. If you had to get cancer, not that I want anyone to get it obviously, but this would be the best type if you had to get it because it's very easily treated. What happens is the stratum basal cells, they're proliferating, meaning they're going through producing new cells, and they slowly start to move down and invade the dermis and hypodermis. How do you treat it? You remove them. And how do they remove them? Oftentimes they can either go in and surgically cut it out. Oftentimes what they'll do is use liquid nitrogen and freeze them off to kill them. So they can look like different things, but any type of abnormality, as you can see here, it's not really a discoloration much, but you just have that excess growth there. I have had numerous rounds of basal cell carcinoma. In just about all the cases, I'm the one that detected it first, went to the doctor and said, okay, I've got this abnormal spot here. my point of sharing that with you is you know what is normal for you. And so whenever you notice something that is not normal for you, get it checked out. Squamous cell carcinoma is the second most common type. Now, this can metastasize. It's involving now the keratinocytes in the stratum spinosum layer. Usually it starts as a reddish area on the scalp, ears, lower lip, hands, areas that are often exposed to the sun. So there's usually a very good prognosis with this. Once again, usually it's going to be removed surgically. Extreme cases, they may have to use radiation for it. So that may be what squamous cell looks like. Once again, each person is going to be a little bit different. Melanoma is the most severe. This is very highly metastatic, meaning it can spread. And it's the most dangerous type. It can spread. Sometimes it can spread quickly. You definitely need to have this one treated. Usually they will treat it depending on the site where they will use surgery to basically cut it out. And then they may have some immunotherapy afterwards. It just depends on the individual case. So for any of these, how do you detect? The ABCD rule. A, asymmetry. If the two sides of a pigmented area, if they don't match, check it out. If the border is not nice and smooth, like a mole is usually nice and smooth. If it has an irregular border, all these indentations, get it checked out. The color, if it contains several different colors, not just, like a mole is usually just black or brown. If it has several different colors, check it out. The diameter, D. If it's larger than the size of a pencil eraser, get it checked out. And some of these I've done comparisons to moles. If you have a mole that suddenly changes, get it checked out. So this is showing what an example of a melanoma looks like. One thing I will say with cancer, skin cancers, please, a lot of people certainly now, as compared to when I was a kid growing up, we didn't know about being careful about in the sun. Parents said, oh, go out and play in the sun. Sunscreen, what was that? We didn't put anything on. Now at least we know that. The recommendation, I don't care what your skin coloring is. I don't care what skin type you have. I don't care how beautifully you tan. The recommendation is always wear a sunscreen of at least a 15. Protection is better than dealing with cancer down the road. Like I say, now melanoma can spread fast. Some of the others, it takes a while. Some of the rounds of cancer that I have had for the basal cell cancer, it's because of my exposure as a kid, years and years ago, that's showing up now. Another problem that we have is that some people think, okay, I will go out in the sun, but I want a beautiful tan, so let me go to a tanning booth. Those can be just as dangerous. Just please be careful. Burns. This is tissue damage. It can be caused by heat. It can be caused by electricity. You have an electrical burn, radiation, certain chemicals. The first immediate threat that you have is the individual, depending on the severity of the burns, is becoming dehydrated and getting an imbalance of your electrolytes. If you have an imbalance of electrolytes, that can lead the individual to go into shock and have kidney failure or shutdown. To evaluate burns, they use the rule of nines. And that's where the body is broken into 11 different sections. And each section is about 9% of the body surface. So you're using that while you're trying to estimate the amount of fluid lost to try to see how close is this person to becoming dehydrated, how bad, how severe is the dehydration. So this is how they divide the body up, as I said, into these, using this rule of nines to determine or at least estimate the amount of dehydration. So we classify burns according to their severity. A first-degree burn is when just the epidermis has been damaged. Usually you're going to have redness, not all over the body, but just localized. You're going to have some edema, which is swelling, and some pain. Remember, you have, in the epidermis, you have those 3 nerve endings, so they've been stimulated. So you're going to know that you have the burn. Second degree burn is when now not only the epidermis, but also the upper dermis is now damaged. And this is when you get blisters. First and second degree burns are often referred to as partial thickness burns because you're not involving the entire dermis. You're still going to be painful. Third degree burn. Now this is often referred to as a full thickness burn because now you're involving not only the entire epidermis, but the entire dermis as well. Not just a portion of it, but the entire thickness of the skin is now involved. The skin color turns kind of a gray-white. It can be bright red. It can be black. There's usually no swelling. And initially the area is not painful, and that is because you've destroyed the nerve endings. Most cases you're going to need some type of skin grafts. So this picture over here on your left is showing on the fingertips you've got reddening. That's a first degree burn. There's some swelling occurring here. You've got blisters down here. This is a second degree burn. Over here you have a third degree burn. You have, huge discoloration. Now, initially, because the nerve endings initially have been destroyed, there's not pain, but you're going to feel it later as those nerve endings start to regenerate. Burns are considered critical if over 25% of the body has second degree burns, or if over 10% of the body has third degree burns, or if the face, hands, and feet have third degree burns on them. What is the treatment? When you have burned skin, certainly what you would see in third degree burns, you need to remove that burned dead skin. That's called debridement. That's going to be painful. You certainly have to treat antibiotics because you're worried about infection. You have lost that protective layer. And so now it's very easy for any type of microorganism to just penetrate right through. And so you're going to want to start the patient on antibiotics to prevent infection. You're going to want to put some type of a temporary covering over to prevent infection, but also to prevent the dehydration from occurring. And as I said earlier, you're going to have to do skin grafts. So this chapter covers the different layers of the skin, some of the different functions of the skin, and then here at the end, we've talked about some basic disorders of the skin. We've also talked about the accessory structures, the hair, the nails, sweat glands, oil glands, etc., that are also associated with the integumentary system, with the skin. Huge role of its protection. As I mentioned at the beginning of this, the skin is considered an organ. It is the the largest organ in the human body. And most of what you see, remember, is dead on there.